Hello everyone and welcome. In this video, we are laying the foundations of epidemiology, one of the most important disciplines in public health. Here is the shift I want you to make right away. Instead of thinking about one sick patient in front of you, epidemiology asks you to zoom out and look at entire populations, a school, a city, a country, to find patterns in disease and figure out how to prevent it. By the end of this lecture, you will be able to define epidemiology, distinguish descriptive from analytic approaches, apply the person place time framework, calculate basic measures like incidence, explain the epidemiologic triad, and see how all of these traces back through history to the tools we use today. Let's get started. So, what exactly is epidemiology? At its core, it's the study of how disease is distributed in populations and what determines that distribution. Notice there are two halves to that definition. Distribution answers who, where, and when, the descriptive side. Determinants answer why and how, the explanatory side. This is a fundamentally different lens than clinical medicine. A physician treating a patient asks, "What's wrong with this person and how do I treat them?" An epidemiologist asks, "What's wrong with this population and how do I stop it from spreading or recurring?" I like the metaphor of the detective here. Epidemiologists don't just patch up the damage illness causes, they investigate why it is happening in the first place, gathering clues until the picture becomes clear enough to act on. Now, within epidemiology, there are really two complementary modes of investigation, and it's worth separating them clearly because you will see this distinction throughout the field. Descriptive epidemiology comes first. It paints the picture using person, place, and time, who's affected, where, and when. Think of mapping flu cases by neighborhood and week. That work generates hypotheses, educated guesses about what might be causing a pattern. Analytic epidemiology comes next. It tests those hypotheses by comparing groups. This is how we proved decades ago that smokers develop lung cancer at dramatically higher rates than non smokers, not by observation alone, but by systematically comparing exposed and unexposed groups. Keep this pairing in mind. Descriptive epidemiology asks what's happening, and analytic epidemiology asks why is it happening and can we prove it? Let's talk about why any of this matters. Epidemiology is the foundation of public health and it does four things really well. It detects outbreaks early before they spiral out of control. It identifies who is most at risk, which let us target interventions efficiently. It guides public health policy, turning raw evidence into action. And ultimately, it prevents disease rather than just responding to it after the fact. Consider two questions almost everyone has heard answered with confidence. How do we know smoking causes lung cancer? And how do we know vaccines work? Both answers came from decades of rigorous epidemiological research, large population studies, careful comparison groups, and statistical analysis. Without epidemiology, public health decisions would be based on guesswork, anecdote, and intuition instead of evidence. That's a genuinely dangerous way to run a health system. Let's ground all of this in a concrete, real world scenario that we will return to several times in this lecture. Picture a large food festival. Thousands of people attend, sampling food from dozens of vendors. Several days later, public health officials start receiving reports nausea, vomiting, fever, fatigue. But here is an important deal. Not everyone who attended got sick. So immediately a critical question emerges. Are these cases even related to each other, or is this a coincidence? That's exactly the kind of question that kicks off a real outbreak investigation, and it's the question we will use as our through line for the rest of this lecture. To answer are these cases related, epidemiologists reach for their most fundamental tool person, place, and time. This is the backbone of descriptive epidemiology, and you will use it constantly. Person asks who is affected, their age, gender, occupation, underlying health conditions, behaviors. Place asks where the exposure happened, a specific location, region, or environment. Time asks when symptoms began and whether there is a pattern, a cluster, a sudden spike, a slow build. Individually, each question is simple, but as together and systematically across dozens of hundreds of cases, they start to reveal a shape, a pattern that points toward a cause, well before any laboratory tests confirm it. Let's apply person, place, and time directly to our food festival. In terms of person, were the people who got sick concentrated in a particular age group, children, older adults, people with existing health conditions? In terms of place, did they all eat at the same vendor or cluster around one part of the festival grounds? In terms of time, did symptoms start within a few hours of eating, which would suggest a fast acting toxin, or after a day or two, which points toward a bacterial or viral cause? Here is the key insight I want you to walk away with. If investigators find that most of the sick attendees ate at the same vendor and got sick around the same time, that's an extremely strong clue, often strong enough to identify the likely of source before any test lab comes back. That's the real power of descriptive epidemiology, the speed. Beyond identifying patterns, epidemiologists also need to quantify them, and that's where two core measures come in incidence and prevalence. Incidence is the number of new cases divided by the population at risk over a defined period of time. It measures risk, how fast disease is spreading right now. Prevalence is the total number of existing cases divided by the total population at one point in time. It measures burden, how much illness exists in total, old and new cases combined. Let's make this concrete with our food festival. 500 people attended, and in the following week, 40 became ill. That gives us an incidence of 40 divided by 500, which is 8% or roughly 1 in every 12 attendees. That single percentage does a lot of work. It tells investigators how serious this outbreak is, and it gives them a number to track over time to know when the outbreak is truly over. Here is a quick check for you. I would genuinely encourage you to pause the video here for 30 seconds before I walk through it. Picture this. A school reports that 20 students are sick. Using everything we have covered so far, what would you investigate? Person. Which students are affected? Are they concentrated in one class or one grade? Place. Did they all eat in the same cafeteria or spend time in the same classroom? Time. Did the symptoms start on the same day or after the same meal? If you found yourself asking those three questions instinctively, you're already thinking like an epidemiologist, and this is precisely how real investigators begin narrowing down causes before a single lab result comes back. Now let's shift from describing outbreaks to explaining why disease happens at all using a model called the epidemiologic triad. There are three interacting components. Agent is the actual cause of disease, a bacterium, a virus, a toxin. Host is the person affected, their age, their immune status, their overall health. Environment is the external conditions surrounding the interaction: weather, sanitation, crowding, water quality. The key idea is that disease doesn't appear because of any of these alone. It happens when all three interact in just the right way to allow transmission. Change any of the corner of the triangle and you can break the chain of transmission entirely. That's actually the theoretical basis for almost every public health intervention you will encounter. Let's apply the triad to our food festival one more time. Agent, most likely a bacterium living in contaminated food, something like Salmonella or E. coli. Host, the festival attendees themselves, some of whom, due to age or underlying health, were more vulnerable than others. Environment, warm weather, a crowded festival ground, and shared food preparation and serving spaces, all of which makes contamination and spread more likely. Now, here is the practical payoff. If you wanted to prevent this outbreak, where would you intervene? You could improve food handling procedures, which targets the agent. You could reduce crowding, which targets the environment. You could increase health inspections, which targets multiple points at once. Public health interventions can target any corner of this triangle, and often the most effective response hits more than one at the same time. Let's zoom out and look at where all of this came from because epidemiology has a genuinely fascinating history that spans over 2,000 years. Around 400 BCE, Hippocrates wrote a treatise called Air, Waters, and Places, proposing remarkably early that a person's environment shapes the disease they develop. That's essentially the seed for the environment corner of our triad over 2,000 years before germ theory existed. Fast forward to 1854, John Snow, during a devastating cholera outbreak in London, rejected the prevailing theory that disease spread through bad air. Instead, he mapped every case by location and found they clustered tightly around a single water pump on Broad Street. When authorities removed the pump handle, new cases declined sharply, a landmark demonstration of the power of data and observation, achieved before anyone had even seen a bacterium under a microscope. Next, in 1948, the Framingham Heart Study began following thousands of residents of one Massachusetts town over decades, and it's what first linked smoking and high cholesterol to heart disease, effectively launching the modern era of chronic disease epidemiology, well beyond just infectious outbreaks. And today, we have entered an era of genomic sequencing and AI powered surveillance capable of tracking a pathogen's spread across the entire globe in near real time, as we saw vividly during COVID 19. The tools have transformed completely, but notice the through line. Careful, systematic observation of populations has always been how we uncover the causes of diseases. Let's spend a moment on where the field stands today because it really has been transformed by technology. Big data, electronic health records let researchers spot patterns across millions of patients simultaneously. GIS or geographic information systems let us map disease spread with pinpoint precision, building directly on what John Snow did by hand in 1854. Real-time surveillance systems flag emerging threats within days or even hours rather than weeks, and artificial intelligence is increasingly used to detect unusual patterns in data faster than any human team could manage alone. COVID 19 is the clearest recent example. For the first time in history, we tracked the pandemic's spread across the entire globe in near real time using tools that would have been unimaginable even 20 years earlier. Technology hasn't replaced the core logic of epidemiology, it's just made us dramatically faster at applying it. Let's bring this all together. First, epidemiology studies populations, not just individual patients, and it does so using both descriptive methods, which find patterns, and analytic methods, which test and confirm causes. Second, person, place, and time help you identify those patterns, while measures like incidence and prevalence let you quantify exactly how serious a given situation is. Third, the epidemiologic triad, agent, host, and environment, explains why disease occurs and give us multiple points where we can intervene to stop it. And finally, from Hippocrates all the way to AI-powered surveillance, one thing has never changed. Data, not guesswork, is what drives effective disease prevention. Before we wrap up, let's run through a quick knowledge check on everything we have just covered. Welcome to a quick knowledge check. I kept these to 7 questions. Take your time on each one before I explain the answer. Question 1. During a mumps outbreak, unvaccinated students had a mumps rate 5 times higher than vaccinated students. What kind of epidemiology is this? The correct answer is B. The moment you compare a rate between two groups, vaccinated versus unvaccinated, to test whether an exposure is associated with risk, you have crossed from descriptive into analytic epidemiology. Simply reporting that 12% of students got mumps would be descriptive. Comparing that rate across two groups to test the hypothesis is analytic. Question 2. A dorm has 300 students. 20 already had chickenpox as children and are immune. During an outbreak, 14 of the remaining susceptible students got sick. What is the correct incidence? The correct answer is B, 5%. Incidence uses population at risk as its denominator, not the total population. The 20 already immune students can develop the disease, so they are excluded from the denominator. 14 divided by 280 equals 5%. Option A is the single most common mistake people make with this formula, using total population instead of population at risk, so it's worth mentioning. Question 3. Which of these strategies primarily targets the environment corner of the triad rather than agent or host? The correct answer is C. Vaccination changes the person's immunity, so that's host. Chlorination and antimicrobial soil treatment both act directly on pathogen, so those are agents. Improving ventilation doesn't touch the germs or the person at all. It changes the surrounding conditions, airflow, crowding, shared space, which is exactly what environment means in the triad. Question 4. Which of the following is not one of the three components of the classic epidemiologic triad? A. Agent, B. Vector, C. Host, D. Environment. The correct answer is B. Vector. The classic triad has exactly 3 legs: agent, host, and environment. A vector, like a mosquito carrying malaria, is a means of transmission between agent and host, and it matters enormously in disease ecology, but it isn't one of the 3 triad components itself. This is an easy detail to blur. Question 5. What made Jon Snow's 1854 investigation genuinely groundbreaking, given what he did not have access to? The correct answer is C. Snow had no microscope evidence and no germ theory to lean on. The bacterium behind cholera wasn't confirmed for decades. His breakthrough was proving causation purely through spatial data and careful observation. That's exactly why his work, not a later lab discovery, is considered the founding event of epidemiology as its own discipline. Question 6. What was generally new about the Framingham heart study in 1948 compared to earlier work like John Snow's? The correct answer is B. Snow and most epidemiology before him focused on acute infectious outbreaks with a single identifiable exposure. Framingham showed the same population level thinking could uncover the causes of chronic heart disease by following one population for decades. That's a genuinely different application of the field, not just a new outbreak solved by the same old way. Question 7. A health department wants to know how much healthcare capacity to allocate right now for people currently living with diabetes in their city. Which measure should they use? The correct answer is B. Prevalence. Prevalence counts everyone currently living with disease, new and existing case combined, at one point in time, which is exactly what's needed to plan today's capacity. Incidence would instead tell them how many new cases are appearing over time, useful for tracking risk and trends, but not for sizing today's caseload. And that's a wrap on our knowledge check questions. Here are the references I used for this presentation. Thank you for watching.